Okay, this is going to be a brief presentation on the genetics of dystrophinopathies. We're going to talk about Duchenne and Becker's dystrophy. So dystrophinopathies, dystrophin is a protein that's important in the complex that connects the cytoskeleton to the muscle fibers. So here's this long protein made of many exons that connects actin, which is part of the myosin-actin muscle program, to the cell membrane to stabilize it. This complex is important in movement for both skeletal and cardiac muscles. So let's talk about Duchenne's muscular dystrophy. When the dystrophin protein that I just showed you in the previous slide is non-functional, there's no connection to stabilize the cytoskeleton to the cell membrane. As such, the muscle contractions rip the cell membrane every time the muscle contracts. When there's rips, little holes in the cell membrane, creatine kinase, or CK, is a source of energy, and it gets outside the cell. In and of itself, it's just a sign that there's damage or rips in the cell membrane. Elevated CK in the bloodstream is a sign of muscle disease. So the elevation of CK isn't a problem in and of itself, except for sometimes when it gets too high, it can cause kidney problems, but it's a sign that there's a damage to the muscles. This occurs when there's damage to the muscles. CK is also important for energy, and so depletion can decrease the muscle energy that's available. Now, actually, the bigger problem when there's rips in the cell membrane is that calcium goes in these same openings that are supposed to be tightly controlled with all kinds of receptors, but these rips allow things to come and go as they will. And over time, and what happens is this excess calcium activates proteases, which destroys the muscle tissue. So it basically eats the cell apart. And so over time, the muscle cells are taken over by fat cells. If I see a newborn who is at risk of Duchenne's muscular dystrophy, sometimes even though they don't have any evidence of muscle disease at the time when I'm seeing them, their CK might be like 20,000. If I see a 10-year-old that has very severe symptoms, a DMD, their CK is still elevated. Normal's up to, let's say, 400 or 500, depending on the lab you're sending it to. It might be like 2,000 or 3,000, which is far less high than 20,000, but it's because there's so little muscle that we're not seeing as high of a level. So Duchenne muscular dystrophy occurs in about 1 in 5,000 males, and it's inherited in what we call X-linked recessive fashion, although we're going to talk about why I don't like to use the word X-linked recessive ever. When I went to medical school, they said females that carry 1 functional copy of this gene and 1 non-functional copy of this gene, while they're at risk of having children. With DMD, especially boys, they're not at personal risk, and that turns out to be false, which half of what I learned in medical school has since turned out to be false. Sorry to tell you guys this. Anyway, there's progressive muscle weakness, calf hypertrophy, lordosis, and you can see as the child gets older, there's more and more lordosis and toe walking. They're usually wheelchair bound by about the age of 16, and death occurs in late teens to early 20s because of heart failure, and this is because of dilated cardiomyopathy. As I said earlier in this presentation, it affects the muscles of both the peripheral muscles and the heart muscle, and the heart is the most important muscle in our body. So on physical exam, there's muscle weakness in both the upper and lower extremities. Proximal muscle weakness is greater than distal, and there's calf hypertrophy, so this is the enlargement of the calves. And one of the things, I know there's a number of slides, I looked through some of the things from other people on the Gower sign, and this is actually the difficulty getting up from a sitting position. So I want to just show you a video of a little boy with Duchenne's muscular dystrophy. And I'm going to show it twice so you watch the way he stands up and he kind of walks up his legs, and notice he did not lose his stickers on the way. But I just want to show you how he finds a way to do stuff. He stands and it's because of his proximal muscle weakness that he needs to do this. Dilated cardiomyopathy, as I was saying earlier, is the #1 cause of death in these patients. Because of the weakness in the muscles, the heart becomes enlarged like a big balloon. And this results, even though it looks big, it's not functioning correctly. So here's a normal heart, and here's a dilated cardiomyopathy. This muscle is not contracting correctly. And as I said, this is the most common cause of death. Becker's muscular dystrophy is a milder form caused by a mutation in the dystrophin gene. So why do they have different names? Because things used to be named clinically. You saw a patient who presented at 6 and they had this and that and the other thing, and you called it Duchenne's after some Dr. Duchenne muscular dystrophy. And then people that presented similar symptoms later were called Becker's. We've since realized it's caused by a change in the dystrophin gene, and that's why we kind of call them dystropinopathies. So in Becker's, you make some protein, but it's a little bit shorter than it should be. So it doesn't quite, it attaches the actin to the cell membrane a little bit, but not as well as it should. So the CK is not as elevated as early. It's milder symptoms, but these patients usually become wheelchair bound by their late teens and death between 20 and 40 because of heart failure. As I was saying earlier, the gene for Duchenne's is located on the X chromosome. Males only have 1 copy of the X chromosome. Females have 2 copies of the X chromosome. So if a male only has 1 copy of the X chromosome and the gene for dystrophin is absent, then he doesn't have any. A female has 2 copies. There's something called random X inactivation. So unlike autosomes, genes on the X chromosome are unique and females are what we call mosaics. So in some of their cells, the dystrophin is being produced correctly. In other cells, it's not. And so it kind of depends on how lucky you are. If you're a female, that most of your heart consists of genes that have the normal protein functioning, you may be fine. And females that have most of this X as the one that's active and not functioning, you may not be so fine. And a combination can still cause weakness of the heart. So females can have muscle weakness depending on their X inactivation status. Dystrophin is one of the largest human genes. It has 2.4 million base pairs with 79% or 79 exons or coding regions. So that's where the problem is. And here at the beginning is where it binds to actin. Here's where it binds to the cell membrane. And if it's too short, it doesn't have enough space there. So management of Duchenne's or Becker's muscular dystrophy, DMD versus BMD, is physical therapy. They have been doing steroid injections into the muscle, cardiac medications to improve function, and research studies have been exploring future therapy. And one of the future therapies, and these future therapies are going to be the therapy of choice as you move forward into medicine. 80% of patients with Duchenne's have a deletion or duplication affecting exon 51. Remember I said there's 78? This one right here is the most common. The phosphodiemadate morpholine oligomers, or PMOs, charged analogs, bind to the mRNA. So this is how we do exon skipping. So first we have our DNA, and then we want to make our RNA, and then our RNA is the template for the protein. So we make our DNA, but because exon 51 is where there's a stop codon, what we do is we have this PMO here that prevents the RNA. It skips from here to here. Now, the bad news is you get a smaller protein. The good news is you got rid of that premature stop codon. And so you do get some dystrophin. It's a little bit shorter, kind of like a Becker's. So you have your DNA, and when you're making your RNA, this PMO prevents transcription, making a piece of RNA between codons 48 to 51. It skips in. That's what we call exon skipping. This PMO is given by an IM injection on a weekly basis, and it has shown a great deal of promise. The future would be gene therapy, would be, CRISPR or some other kind of, injecting the correct gene into the muscle. And this is something that they're looking at and will be considering in the future. So, a 5-year-old male is having difficulty rising from the floor. He cannot ride a 2-wheel bicycle. His mother has a brother who died from complications of Duchenne's muscular dystrophy. What laboratory test would determine if he's likely to have the same disorder? And the answer is a creatine kinase. This will help us to determine if it's very elevated. And again, if normal is up to 200 and 400, and if it's normal is 200, and again, every lab is different. So whatever you're given these labs, it has to give you what the norm is. If normal is 200 and it's 203, it's probably not Duchenne's. If it's 20,000, it is. The next question is, a 12-year-old boy has a particular genetic disease. I took this out of one of these USMLE books. His mother is a carrier for a mutated gene, but the father is not clinically affected and is not a carrier. The boy has 4 siblings, a sister and a brother who are not affected and not carriers, a sister who is a carrier but not affected, and both who are clinically affected, not affected, and a brother. Sorry, this is a brother. I was like, this doesn't make any sense. A brother who is clinically affected. The inheritance pattern for this disorder is consistent with which of the following diseases? Alpha-1 antitrypsin, cystic fibrosis, Duchenne's muscular dystrophy, phenylketonuria, or Tay-Sachs. So basically, they're giving you this big scenario that he has some disease and his mom's a carrier, but his dad is not clinically, but doesn't have any symptoms, and his dad isn't affected. And he has 4 siblings, and he has a sister and a brother who are not affected, and a sister who's a carrier, and a brother who's affected. So the mom is a carrier for something, and this, looks like an X-linked disorder, because they're saying mom's a carrier, dad's not affected, he has a brother that's affected. So this so this looks more like this is autosomal recessive, this is autosomal recessive, this is autosomal recessive, this is autosomal recessive, this is X-linked. So really what they're doing is they're giving you a disorder that's X-linked. And I could call it Duchenne's, I could say that he has muscle disease, but this is basically the question. They're just trying to get you to X-link, so that's why I put it in here, just to give you a sample question. And that concludes this lecture.